Thank you very much for the kind introduction, and thank you for the organisers for having me speak here today. So I don't have any disclosures, other than to say that I'll give this talk from the perspective of a clinician who sees COPD patients with heart failure in my clinic all the time. This is a very broad topic, the interaction between COPD and heart failure, and as such I'm going to focus on three specific interactions today. Firstly, the prognostic implications of COPD in heart failure patients. I'll then talk about the use of beta blockers in heart failure patients with COPD, and finally consider the use of inhalers for COPD in heart failure patients and some of the concerns that physicians may have. So COPD is characterized by airflow limitation that is not fully reversible, and in this graphic on the left you can see a normal patent airway held open by attachments from nearby alveoli. This is in comparison to the peripheral airway of a COPD patient, where you can see a variable combination of emphysema, destroying alveolar attachments, mucosal inflammation leading to reduction in airway size, and then mucus hypersecretion with luminal obstruction. And ultimately these various pathologies can occur to a variable degree, but the diagnosis of COPD is made with spirometry on the basis of fixed airflow limitation. That's defined by a post-bronchodilator FEV1 FVC ratio less than 70. And this is very important to differentiate COPD from asthma, which has very significant implications in terms of treatment choices. In Canada, in a population over 40 years of age, the prevalence of COPD in the general population is about 4.5%. and it's the fourth leading cause of death. COPD is much more prevalent in heart failure, likely due to shared risk factors, and depending on the population studied and the criteria used to diagnose COPD, prevalence rates have been reported between 10 and 40%. This is data from the US in a Medicare population showing prevalence rates of 30%, and you can see how it compares to other common comorbidities in heart failure. And the presence of COPD in heart failure is associated with poorer outcomes. These are data from the GISI heart failure study, which compared outcomes in heart failure patients with and without COPD. And the authors here found a 20% increase in all-cause mortality in patients with COPD and a 20% increase in hospitalizations and cardiac deaths. And there are several ways by which COPD may lead to poor outcomes in heart failure. COPD is characterized by chronic systemic inflammation, and also it's a high adrenergic state. So the inflammation can obviously lead to potentially accelerating the atherosclerotic process, and the high adrenergic state can have a deleterious impact on cardiac function. Of course, another possibility is that in patients with heart failure and COPD, there's underuse of heart failure medication. And specifically, beta blockers are of relevance in this area. So, we know that obviously beta blockers have become a mainstay of treatment in heart failure due to strong evidence showing reductions in mortality, hospitalizations, and symptom burden, and this is reflected in our heart failure guidelines. However, traditionally, there has been a concern about prescribing beta blockers in heart failure patients with COPD, mainly due to fears of causing worsening bronchospasm and worsening lung function. And these concerns have persisted despite kind of an era of more cardioselective beta blockers being available. This is data from the UK database showing that patients who had COPD and heart failure were about 50% less likely to be prescribed beta blockers compared to those who had heart failure alone. And importantly, in this study, they showed that in more severe disease with NYHA class 3 or 4, there was even a more marked reduction in beta blocker prescription in COPD and heart failure patients compared to heart failure alone. And this underuse of beta blockers has been seen across various heart failure registries from different parts of the world, with a gap in use of about 10% in beta blocker use in COPD patients compared to non-COPD in ambulatory heart failure patients, and approximately a 15% gap in prescriptions in hospitalized patients at discharge. And this underuse of beta blockers can potentially have significant ramifications for outcomes in heart failure patients. This is a slide from the Biostat CHF study, which aimed to investigate up-titration of various heart failure medications in heart failure patients, and they included beta blockers. And you can see in this slide that patients who did not receive a beta blocker, illustrated in red, and those who received less than 50% of the recommended dose of beta blocker, illustrated in green, had a significantly higher risk of death compared to those who had reached recommended dose. Interestingly, in this study, one of the main reasons for not up-titrating beta blockers was the presence of underlying airways disease. So we've alluded to the fact that beta blockers reduce mortality in heart failure, but there's a possibility that beta blockers may also have an indirect effect on COPD. So as I said, COPD is characterized by systemic inflammation and high adrenergic activation. Beta blockers, we know, can reduce that sympathetic activity, but there's also emerging data showing that they can reduce chronic inflammation. So reducing the Th17 response, reducing TNF-alpha levels. So this potentially could reduce exacerbation rates, and in an exacerbation rate where there's higher inflammation, higher adrenergic activity, and hypoxia, beta blockers may also modulate outcomes, reducing myocardial ischemia and tachyarrhythmias, which we often see in COPD exacerbations. Furthermore, we know in exacerbations that patients often receive frequent and higher doses of short-acting beta agonists, so salbutamol inhalers, and potentially the use of baseline beta blocker therapy may modulate any negative effects these inhalers could have on the heart. This is an old slide from a study looking at the use of beta blockers in patients with COPD, and you can see that there's a relative risk of 0.72 for mortality in patients treated with beta blockers compared to not. Of course, this is observational, meta-analysis of observational studies, so it has to be taken, interpreted in terms of confounding biases. Other studies have shown a reduction in exacerbation rates with beta blockers, and this is data from the COPD gene cohort study, a study of over 3,000 patients with COPD. And in this study, the investigators showed that across all levels of severity of airflow limitation, beta blockers reduced exacerbation rate. So this kind of promising observational data led to a randomized control trial. This is a slide from the BLOCK study, which compared metoprolol versus placebo in a randomized trial with a primary outcome of time to first exacerbation. It's important to say that this slide excluded patients who had a primary clinical indication for beta blocker, so that would have obviously excluded heart failure. The study ultimately was stopped for futility and safety concerns. You can see in panel A here, in terms of the primary outcome of time to first exacerbation, there was no difference between metoprolol and placebo. And in the panel B, you can see that the metoprolol arm had a higher risk of severe exacerbations defined by hospital admission. There is another study currently ongoing investigating the role of bisoprolol, so a more cardioselective beta blocker, in a similar population of patients, moderate to severe COPD. But again, these trials have excluded heart failure patients and have excluded patients with a clinical indication for beta blocker. So what kind of information do we have to guide our current practice? This is a slide from the Tornado research study, which was a phase 3 study looking at the lung function and outcomes in patients on a combination inhaler of a long-acting bronchodilator and a long-acting muscarinic agent. And in this population, about 11% of the 5,000 subjects were on beta blockers at baseline for a mix of indications including hypertension, heart failure, and ischemic heart disease. And when they analyzed outcomes in terms of exacerbation over a 1-year period, there was no indication that beta blockers worsened outcomes. Similarly, on this combination inhaler, lung function improved in both groups, and there was no between-group differences in this improvement. Similar data from the SUMMIT study. This is a study of over 16,000 patients with COPD, randomized to a steroid inhaler, a long-acting bronchodilator inhaler, or a combination inhaler of both those, compared to placebo. In this study, 31% of subjects were on beta blockers at baseline, and when you stratify for that baseline beta blocker therapy over a long-term follow-up of about 4 years, there was no difference seen between the groups in terms of exacerbation rate, cardiovascular events, or mortality. So this kind of gives us real-life data showing that beta blockers, when used with an appropriate indication, are safe. In the last few minutes, I'm just going to consider inhaler therapy for COPD. In the last few years, there's been an explosion in the number of inhalers available for COPD, and this varies from short-acting bronchodilators, both beta agonists and antimuscarinics, to long-acting bronchodilators in the same drug categories, and in combination inhalers with long-acting bronchodilators combined together, or with the addition of an inhaled corticosteroid. When we're deciding what inhalers to use, we base this on a combination of symptom tests using the modified MRC dyspnea scale combined with the COPD assessment tool, which takes into account other relevant symptoms such as cough and quality of life indicators. And we also take into account the exacerbation history, because this predicts the risk of future exacerbations. And ultimately, unlike asthma, where an inhaled corticosteroid is the mainstay of treatment, in COPD, the central component is long-acting bronchodilators. So it's reasonable in somebody who's very mild COPD with infrequent symptoms to use a short-acting beta agonist or a short-acting antimuscarinic. But in patients with more persistent and significant symptoms, guidelines recommend a long-acting bronchodilator, either beta agonist or antimuscarinic, either alone or in combination. And we really only use inhaled corticosteroids if a patient has an increased risk of exacerbations. And that's due to the fact that steroids in this population have been shown to increase the risk of pneumonia. So there has to be a benefit-risk ratio that's favorable to outcomes. So just very briefly, over the last minute or two, let's consider these inhalers and their potential impact on the cardiovascular system. These are very older data from looking at beta agonists, short-acting beta agonists, so salbutamol inhalers in patients with both asthma and COPD. And you can see there's a clear difference, significant difference between salbutamol and placebo in terms of sinus tachycardia. The data is a little bit more mixed in terms of major cardiovascular events with a trend but not significant. But I think in clinical practice we all see a variability from patient to patient in their response to short-acting beta agonists. And certainly some patients we know that these short-acting beta agonists will trigger arrhythmias, and particularly in the context of exacerbations. The safety profile of the longer-acting inhalers looks a lot more acceptable in cardiac patients. This is data from the TORCH study, which was a randomized trial looking at a salmeterol long-acting beta agonist compared to a steroid inhaler, a combination inhaler, and compared to placebo. And over follow-up of just over 3 years, there was no difference in exacerbation rate or mortality between the groups. And finally, just to reflect on the other common inhaler we use, tiotropium, which is a long-acting antimuscarinic. And this is data, again, from a randomized trial. And here, this table summarizes adverse events. And you can see in the tiotropium group, there's actually a reduced incidence of cardiac events, including congestive heart failure, in the group on inhalers. I'll finish just by saying that Obviously, there's a lot of interactions between heart failure and COPD. There's a lot of things to consider. We know in practice that differentiating between heart failure and COPD can be very difficult, particularly in an acute setting and acute worsening. There's other things to consider, including how you modify your cardiac rehabilitation program to have a program that reflects the pulmonary pathophysiology. And then we're going to hear later from Dr. Flores about sleep apnea and heart failure. But even in the absence of sleep apnea, COPD patients often have nocturnal hypoxia, and that has implications for heart failure treatment. So these are maybe talks for another day. I'll finish with just some brief take-home messages. COPD is very prevalent in heart failure, and it's associated with increased morbidity and mortality. Beta blockers should be used in heart failure patients with COPD. From real-life data, long-term studies, there's no safety concern. And if you have concerns, you can always follow more closely in terms of initial monitoring after starting the medication. And in terms of inhalers, if your patient is using short-acting beta agonists with increased frequency, that's something to be careful of. But otherwise, the long-acting beta agonists and long-acting antimuscarinics have a very good safety profile. So I'll finish there. Thank you for your time. And I just share a picture of my hometown in Ireland. You can see the Atlantic just on the horizon there looking towards Canada. So thank you very much.